It's a 27-year-old male BCom student resident of Assam who presented with chief complaints of paleness right testicular swelling from 6 months and paleness lump abdomen from 6 months. Coming to history of presenting complaints, he first noticed swelling right testis, which was gradually increasing in size. Swelling was painless. There was no redness or any ulceration. And later on, he noticed 2 into 2 centimeter lump abdomen, which was painless to begin with, and gradually increasing in size up to 7 into 7 centimeter, and causing postprandial fullness. There is no history of fever. There is no history of cough. There is no history of vomiting. There is no history of headache, and there is no history of undescended testes. Family history, there is no relevant family history. Drug history, there is a history of Ayurvedic medicine on and off at 16 years of age for constipation occasionally. Past history, there was a history of road traffic accident in 2014 for which grafting of right thigh was done. However, no injury to scrotum and testes as per patient history. There is no other relevant history. Person history is not an addict. There is no other addictions. Coming to general examination, patient is cooperative and well coordinated with time-based person. Temperature was 98 degrees Fahrenheit. Heart rate was 98 per minute. 110 by 80 millimeter in Hg in supine position. He was averagely built and adequately nourished. There was no pallor, no icterus, no edema, no sinuses, no lymphadenopathy. On local examination, inspection was done in standing and supine position. Left testis was normal and right testis swelling was 10 into 8 centimeter in size. Skin over the swelling was normal. There is no sign of any scar, sinus or any erythema. Coming to palpation, on palpation, findings of inspection were confirmed. There was no local rise of temperature. Size was 10 into 8 centimeter. Was able to get above the swelling. There was no palpable impulse on cupping. Surface was smooth. There was no tenderness, and left side testis was normal. On per abdomen examination, inspection, it was a globular abdomen. Umbilicus was inverted. There were no scars, sinuses, dilated veins, and hernial orifices were normal. On palpation, abdomen was soft. There was no guarding. There was no rigidity. There was no evidence of any free fluid, and 7 into 7 centimeter mass was there, occupying the central quadrant of the abdomen, non-tender, all margins were felt, and skin above the swelling was normal. It was slightly mobile horizontally. There was no movement with respiration, and there was no organomegaly. On percussion, there was no evidence of ascites, and auscultation, vowel sounds were present. Coming to system examination, central nervous system was unremarkable, cardiovascular system was unremarkable, and respiratory system was unremarkable. So coming to the summary, he was a 27-year-old male BCom student with no comorbidities, with gradually progressive swelling and with an abdominal lump. So my differentials, first would be testicular tumor, second would be lymphoma, third would be unlikely cyst, unlikely sarcoma, and unlikely renal cell carcinoma.
I think Manvi, I think you go to the history. I think you have very. So what are the relevant point you have asked in the history?
Sir, sorry, sir. What are the
relevant point? The negative history have you covered? What is the importance of the family history? Is there any importance in the testicular cancer, or not at all? So what history, what negative history you would like to ask, or what history you would like to ask in a case of testicular mass?
So we would like to ask for there's any history of cough or not, there's any history of headache or not, there's any history of fever, mostly there's infective causes we want to rule out.
No, I'm asking in the family history. We'll come to that point after that. In a family history, what you want to know? So in a oncological case, what we want to ask in a family history, what is the importance? Like in a breast cancer, Do you want to know the family history?
Yes, so in breast cancer, we would like to know.
So in testicular cancer, there is association, but there are certain cancers which has a very, very rare association, and some cancer might not at all, and some cancer may have a strong association. So breast, ovary, prostate. So these are the associated with a strong association with the. So is there any testicular, whatever the data or available literature says? So is there any familial predisposition of a testicular cancer?
Isochromosome 12p has an association. I don't know
No,
otherwise.
it's not a. I'm asking for a familial.
Family history, I don't have any idea.
So, though we have not come across, but whatever the literature says that the twins and the history of family history of at least in father, those who have a they have, I think, 4 to 6 times more probability of developing a testicular cancer. Although they have not able to exactly specify the locus from where, but the pool data of the whatever in the Western world, they said that there is some association between the familial history of testicular cancer and the family who have a, or father who have a testicular cancer. The offspring are at increased risk of developing 4 to 6 times more common than the normal population. Though if you ask me, have you come across? Not very commonly, but that is the what literature says about that.
Okay.
I think I will request others to also who are there today to ask Dr. Vanita, Vijay, and Nandini. They can ask or other. I think Lingraj is there, so they can also ask. And Kumar is also there, so I think they can also ask if there is any relevant. I think just summarize. Dr. Kumar has just joined. Manvi, just summarize the case for others.
Yes, sir. Is a 27-year-old male patient, BCom student with no comorbidities, who presented with right testicular swelling along with the abdominal lump.
So in the negative history, what other thing which you would like to ask?
The negative history would like to ask for cough, would like to ask for any bony pain.
No. But when you ask a negative history, you should have an answer why you what you want to correlate with that negative history. So if you are asking for a cough, why you want that? What I meant. So what is in your mind when you asking this question?
So 10% of patients will have some of the manifestations. So cough, we would like to ask to rule out any lung mets, and pain, bony pain because of bony mets, which we would like to rule out to the.
But how common? No, I think that is the mistake. How commonly you see a bony metastasis in a testicular cancer? How commonly have you seen? So I think that is one thing which I want to just don't push on those negative history which are, because the examiner will then screw on that how common is the bony metastasis. Very rarely in a testicular cancer. So try to avoid those negative history which is very rare in that cancer scenario. Other other history which you have taken about the, so what are the other negative history you have asked? So one is the cough, which still can be explained, but bony pain is not that common.
So we would like to ask for headache and CNS symptoms because brain mets are seen.
Yeah, you can keep it lower down, but not a very common symptom. Any apart from that?
Apart from that, sir.
Lingraj has asked a good question about, because when you're asking your history, that you also want to have in your mind some etiology. So you want to ask about some questions that how you going to differentiate this. I know you might be thinking testicular tumor, RMS, especially this age group bit on the other side, but third one will be your hematolymphoid disease or hematolymphoid malignancy. So what are the questions you will be thinking of asking?
So for NSCCT is most common between 15 to 35 years of age. So age will be one of the most important questions. We would like to rule out that, and then.
So that you have additional to what you have said.
So B symptoms, we would like to see whether B symptoms are present or not for lymphoma, for doubling of lymphoma. And history of undescended testes, we would like to rule out.
So it will be swelling in other places. You will have any bleeding tendency anywhere, any bruises anywhere. So these are certain things which may help you deciding, okay, where we are going to. If you're think about having patient having lymph node all over the place, generalized lymphadenopathy and bleeding tendencies, then it will give you some clue about what you are dealing with. Go ahead, continue. Lingaraj, you wanted to add something?
No, sir. That much. So, Manvi, if you say testicular germ cell tumor, anything against in this patient which is not fitting into? You said a large abdominal lump.
So for against testicular tumors.
Yeah, testicular germ cell tumor. Usually testicular germ cell tumor, when you see abdominal mass, they are retroperitoneal nodes, and they usually cause back pain, and unless they have grown so much, and there is abdominal lump. I'm asked comments from Kumar sir and Amit sir also. So is it a relevant thing, sir, like back pain when you have a large RP mass in a chest, the germ cell tumor?
Agree with you, Lingaraj. In fact, the moment you have a lymph node of around medium size, usually you will have some back pain, and that is one of the clinical trick to know, in fact, that it is resectable or not. Also, that is one of the trick to know about it.
In fact, some of the young patients underwent MRI for back pain evaluation, and then they found that there is a mass in the MRI, and then they further worked up. So we see, at least if the tumor mass is say more than 6-7 centimeter, patient may present with a dull aching back pain. We can come across with there is a large abdominal mass. I think the other on clinical examination, what other thing you would like to see in a suspected testicular cancer patient in a general examination? What are the other things which you like to see?
Lymph nodes are present not.
Before that, which in a clinical examination, which group of nodes, by the way?
Clavicular lymph nodes, inguinal lymph nodes.
Inguinal lymph node, how commonly come across an inguinal lymph node? When you will suspect inguinal, suppose if you get a 1 centimeter, 1.5 centimeter inguinal node in a testicular cancer, will it be significant in this case, or when it will be significant? That's what I meant. Inguinal node is not common, not at all. You should not. You have to be even you get a inguinal lymph node, you have to prove it that it's a in a testicular cancer. Which group of lymph node you will? That what my question. The clinically palpable. Apart from the para-aortic lymph node, which lymph node group you will you can see? So I think the left supraclavicular is the most common. Inguinal lymph node involvement in a testicular cancer can happen in only two situations. One, when there is a breach in the testicular skin, and that lymph, and that is the region, or rarely when the para-aortic lymph node is very high, and then there is a retrograde transmission of the through the lymphatics to the common iliac, external iliac, internal iliac, then the inguinal lymph node will come. Why this is there? What is the physiological basis for this?
Mannavi sir, testis का lymphatic drainage पूछ रहे हैं तुमसे.
Yes. So you said inguinal lymph node. Don't say that inguinal lymph node. It's very uncommon.
Yes.
So what Vijay asking replied to that question, that have relevance in this scenario. So what is the lymphatic drainage of a right testicular and left testis, and why? Why this is there?
So right testicular lymphatic drainage or aortic and para-aortic lymph nodes, and left will drain to left renal, and then.
No, that is not the correct answer. You everyone, so you have to be read little bit of this. That has an importance into the. So left usually goes to the para-aortic and pre-aortic, and right we want to know the first landing zone. Then at some point of time, all the lymph node will get involved, because also first landing zone for a right side is inter aortocable, and the left side is para-aortic and pre-aortic. When the tumor size, the lymph node size increases because of the increased proliferation rate, the tumor, then all other lymph node. Why it is this?
So I don't have any ideas.
No, why this lymph node pattern? So I think that is the reason we in the first year we used to forced to read about embryology. So what is the reason why the para-aortic is the first landing zone, not the inguinal, or for a penis, what is the landing zone?
So
The penis. Can you hear me? One way. Hello.
yes, sir.
So my question is, what is the first lymph node station which gets involved in a CA penis? Inguinal. And for a testicular, you told the para-aortic, pre-aortic, inter-aortic. Why it is this? So, I think you should read about it.
टेस्टिस एम्ब्रियोलॉजिकली आता कहाँ से है?
सर
टेस्टिस एम्ब्रियोलॉजिकली कहाँ से डिसेंड करता है?
So that is the reason the undescended testis. Why there is undescended testis?
that descends from the third month में इलेट में रहता है, उसके बाद नीचे डीप इंगुइनल रिंग, इन्वॉल कैनाल, एंड देन सुपरफिशियल इंगुइनल रिंग, एंड फाइनली रीचेस द स्क्रोटम.
So the proper way of explaining is that these are the intra-abdominal organs. During embryogenesis, they get their blood supply and lymphatics from the nearby organ. So that is the reason the testicular artery is a direct branch of the aorta. So they similarly the lymphatic drainage of this testis is to the pair, because at the initial embryogenesis, the testis is usually very close to the aorta. So the blood supply, the lymphatics usually near the aorta or from the venous supply and arterial supply. Then the testes start descending, and but you told that during further process it comes down to the scrotum. So that is the reason the testes have a first landing zone in the para-aortic and pre-aortic interval, while the penile region has a first drainage to the this inguinal region. So that little bit you should know, because sometimes the examiner wants to know about the that question will come in at the time of the RPLND. What sort of read little bit about the lymphatics, the embryonal about that.
Yes, sir.
तो इंग्वाइनल लिम्फ नोड नॉर्मली मन्नावी रीजनल लिम्फ नोड नहीं माना जाता है, हाँ, टेस्टिकुलर कैंसर के लिए. एक सर ने बताया आपको, अगर टेस्टिस का स्किन ये हुआ रहेगा तो वो जा सकता है. दूसरा एक, अगर हर्नियोग्राफी या हर्निया रिपेयर का पहले का हिस्ट्री रहेगा तो भी जा सकता है.
Yes, so that is one history which you could have asked about, that if there is another history which I was asking any in this patient which might have because he underwent some trauma and all that. So that was the reason I was asking ki, do you know that suppose if this patient would have a inguinal lymph node with a history of, then that might not be a so that may be spread through the scrotal skin going to the inguinal area. Another important history point that what the examiner sometimes some examiner wants about the Klinefelter syndrome, the features of a Klinefelter syndrome. why you want to see the features of a Klinefelter syndrome in a testicular cancer, or just they want to know whether other secondary sexual characters are well developed or not? What is the reason for that? Physiological reason in testicular cancer cases?
Gynecomastia is seen, sir. Otherwise, I don't think.
Gynecomastia, that definitely, that is one question which I want to come to there. You have to ask about gyneco. Before that, why I want to stress on the Klinefelter syndrome or testicular what we call as a testicular dysgenesis syndrome in a testicular cancer patients. Why am I stressing this point?
It has some association, sir.
Why? What association? So you have to so in the Klinefelter syndrome, the gynecomastia, the arm span. So sometimes some examiner want to listen that whether you have looked into that aspect or not, because these are the syndrome what we call as a testicular dysgenesis syndrome, which has a very strong association with developing the testicular cancer. So all sort of, that is the reason the patients who underwent for a infertility evaluation, the probability of getting a testicular cancer is 4 to 6 times more common than the normal population. So sometimes some patient may get a testicular a very early testicular cancer during evaluation for infertility. So some sort of testicular dysgenesis is directly related to the genesis of this may be related to the increased FSH level. There are various hypotheses. The exact cause is not known, but there are various hypotheses regarding the FSH, high FSH because of that, the early damage to the gonadal cells during embryogenesis because of the placental migration of estrogen. So that is the reason the testicular dysgenesis or infertility, maybe these patients are at increased risk of developing the testicle. So you have to ask these two questions in the, is there any secondary sexual character are well developed or not, the which is matching to the age of that patient, and the some features about the Klinefelter syndrome like gynecomastia. What is the region of gynecomastia in physiological region?
Sorry, sir.
The physiological basis of a gynecomastia in a testicular cancer patients. So I think you have to read little bit about this also, because sometimes the examiner may ask about this. This is because of the decreased testosterone production may lead to FSH, which might have led to the I think the beta subunit or of the beta subunit of SCG has some similarity with the LH. So that will lead to the increase, and we know that the this is responsible for the some sort of gynecomastia, and the patients who are already hypogonadism have an increased level of the SCG in their blood. So that will lead to indirectly lead to the gynecomastia. So some points about the clinical baseline clinical examination is very much you should little bit focus on that also during clinical examination.
Yes.
I think now go to the investigation and all that.
So the investigations were done, and complete blood count by HB was 7.1. Total leukocyte was 5.24. Platelets were 1,99,000. LFT albumin was 2.9. OTPT RXT by 99. RFT urea was 21. Uric acid was 2.6. Creat was 1.1. Tumor markers baseline was AFP was 53,062. Beta SCG was 2,072. LDH was 1,129. And PFT was having severe restriction, and DLCO was reduced. Should I start with CT scan?
No. See, so how you will proceed? So so patient come with this. So how will like to go ahead with this in this case?
Yes. So we will first take the history and physical examination, and then we will do the routine labs, including the complete blood count, renal function test, liver function test, and tumor markers. LDH, beta HCG, and AF alpha fetoprotein. Then we would do the pulmonary function test. Apart from that, we would, imaging, we will do the CECT, contrast enhanced CT scan of thorax, abdomen, and pelvis.
Then,
And we will
so ultimately you have to decide a plan for him, na. So what will be your plan?
so plan would be, sir, since EFT is having severe restriction and DSC is reduced, so we would not be able to give him a bleomycin based therapy.
No. So have you? No, I think that the mistake you are making, Manvi. Have you established the diagnosis fully?
For him, sir, as the beta 2000 and alpha fetoprotein is 53,000, so it comes in
Comes into
poor risk.
why poor risk?
So alpha fetoprotein is more than 50,000, sir.
So in the case of testicular cancer, the good, intermediate, poor risk is defined from which? So it's a pre-orchidectomy marker or post?
It is post orchidectomy markers.
So then, suppose this patient still have suppose this patient would have a 5 centimeter testicular tumor and a 2 centimeter abdominal mass, then what would you have done? So how you can define a poor risk in this case? These are the baseline marker pre-orchidectomy. You cannot decide the risk based on the pre-orchidectomy marker. So first, so in a straightforward testicular lump which is hypoechoic on sonography with the raised tumor marker, what will be your first step?
So we will do the high inclinal orchidectomy. Then we will take the markers which come after that.
So you should not miss. You don't say immediately that we like to go ahead with the any chemotherapy. So don't jump on that. Yes, so to be careful. Examiner will say, why you are not giving him, why you are not discussing with the neurosurgeon.
Also.
इस पेशेंट का TLS का रिस्क है?
Yes, I think it's a good question. And you have yes.
Disease is bulky, so the abdominal mass is bulky one, so and testicular swelling is also a large swelling. Tumor markers are raised, so there is a risk of TLS.
LDH भी raised है ना इसका?
Yes.
इसका HB 7.1 क्यों है, मन्नवी?
So causes could be, sir, nutritional cause, and also it could be some retro. This patient was not having, but sometimes retroperitoneal nodes will cause some GI bleeding, sir. Yeah.
बहुत रेयर है वो टेस्टिकुलर कैंसर पेटनोल.
It's very rare. So
इसका एनीमिया का वर्कअप किया था?
No, sir, it was not done, sir.
लेकिन हो सकता है एल्ब्यूमिन भी कम है इसका, 2.9 ही है ना, तो न्यूट्रिशन.
बट विजय, MCH, MCHC, PCV ये सब तो होगा.
Yes.
एल्फ्रिस स्मीयर तो होगा.
That was Jones and not noted. Sorry, sir.
Vijay, continue. I just wanted to interject that, and especially for students, I do agree we won't have the full workup for every situation, but there will be lots of evidences available in many of those clinical examination and the reports which can give you a clue. Continue, Vijay.
इसका PFT इतना रिस्ट्रिक्टेड क्यों है? DL से कम क्यों है? स्मोकर है?
No, sir, he is not a smoker, sir.
27 years का है ना? तो मैं पूछना चाहता था तुमसे कि अगर बहुत लार्ज एब्डोमिनल मास होता है तो उससे PFT के असेसमेंट में प्रॉब्लम होती है?
That could be possible, sir. the mass is huge one, then there might be some compromise which would have been happening at that time. So come to PFT pattern. So you might not be doing it properly.
Okay. Okay.
But which component will be affected more in the PFT DLCO? Which component because of the restricted movement of the diaphragm?
DLCO forced
Yes, so DLCO will less affected. The FEV1 and FEV, that might be. So in this case, how you? Yeah, I think what the Lingaraj is saying is absolutely right. So that has to be seen in the context of the. So we should not jump on that immediately for not giving glio until unless there is a clear-cut indication or contraindication not to use. If there is no factor found, we might have to repeat it and discuss with the pulmonologist regarding this in patient when there is a no lung metastasis, diffuse lung metastasis. The patient is not a smoker. Suddenly why the DLCO will be on lesser side. We have to find the cause before deciding for that. So any other two investigation which you would like to go in a case of testicular cancer before going for a definitive treatment? Suppose so in this patient, because of the large testicular lesion and large abdominal mass, you might have decided for a upfront chemotherapy. Suppose for the time being we will not take it as abdominal mass, so it's a 7 centimeter testicular lesion only. So then what would your investigation of two important things which you have missed in the investigation before going? Sorry?
Sonography in the local region we would like to do.
So not local is evidence. The answer is partly correct. We want to see the other testes also, because in 1 to 2% that might be the synchronous. Other testes might get, which is not very common, but definitely we want to see. And for future reference, we need to see the opposite testes. So 1 USG and still 2 are remaining before going for any treatment. In fact, I will say 2 at least. And now the third also has come into the picture. So I think most important for a young testicular patient before taking him for either chemotherapy or architectomy, the fertility, yes, fertility should come into the question. So is he married?
He is unmarried, sir.
So whether married or married, you have to ask for that. That you have to remember for any young, not testicular, for any other young cancer, because these are the curative malignancies. Patient have a good chance of a cure. So from that aspect, you have to ask. So you should not miss that point. The fertility question has to come. That is a very, very important. And if there are certain examiners who like to see, and it's not about the exam, it's the day-to-day practice. So that you have to ask for a sperm analysis and SOS banking. Why it is important? Why we are so much paranoid about the semen examination and banking in a testicular cancer patient?
The infertility will happen because of the chemotherapy and also because of the disease also.
So you mean to say that with chemotherapy the infertility, what is the other reason?
सर पूछ रहे थे कि सीमन एनालिसिस के फाइंडिंग क्या रहता है नॉर्मली टेस्टिकुलर कैंसर में?
Yes, I think Manvi, you have to read a little bit about this. These are the, everyone, you must have read about BP. Everyone knows that you would, but these are the important questions. So how many patients of a testicular cancer have a agiospermia or oligospermia at the baseline before starting the therapy? So that was a question which we were discussing about the testicular dysgenesis indirectly. So if we do a random 100 patient of all stages, how many patients will have a oligo or agiospermia or some sort of sperm motility disorder? What I meant to the 50%. So 50% patient may have a, from the, before giving any treatment, before giving any therapy, they may have a some sort of testicular motility or this the morphological some disorder. So we want to know And second thing, what you told about, because we are going to give chemotherapy, there is a chance that they may get. So how many patients? So I think what I meant that you have to read about, or all the students have to read about the infertility or the cancer, testicular cancer with infertility. What is the incidence? What is the baseline? What are the techniques for this? Why we need to do that? If the patient is not able to produce the sperm, is there any other assisted reproductive technique or not? So I think that one question you have. A second, the important, you have not mentioned about the pure tune audiometry. That is, we usually do in patients whom we are going to give the cisplatin for at least 3 or 4 cycles. So that you have not mentioned. That has to come into the picture, because definitely we need to that. And third, in this case, because of the high AFP, so that was a little bit controversy. But I think last time when we discussed with our residents, the AFP cutoff for doing a MRI brain has now, I think it's 10,000. So that have changed. Why they have changed? What is the the basis for that? That I tried to look, but I couldn't find. But they have, I think, come up with the doing a MRI threshold of doing a MRI. They have cut down. They have decreased. I think it's AFP 10,000 and beta CG 5,000. Gautam, can you exactly what that was the case you presented on the, what is the final cutoff in that for doing MRI? Gautam is not there. So I think it's around 10,000 for AFP, and or that I have to exactly check the number, but it is not in the same previously what we used to follow. That next this NCCN has changed it. So these three you have to do. I think. So in this patient, what you have decided to go ahead with, so then you have to say that in view of a very large abdominal mass with a large testicular, what is the problem of going for why we want to avoid architectomy of front?
So why would I like to avoid?
Yes.
Wouldn't hurt. Sir, could you please repeat the question, sir?
So why you want to go ahead with chemotherapy in this case upfront? Somebody will ask now why the patient has not been subjected for architectomy. That is the high inguinal architectomy is but both diagnostic and therapeutic. For that is the line we used to read now, that is both diagnostic and therapeutic for any testicular the lesion which is otherwise not otherwise proved to be any other thing like epididymis, status and all that. If you have ruled out after a course of antibiotic, USG showing a hypoechoic lesion, and in this case the tumor markers are raised. So in a straightforward case, we'll go for high inguinal architectomy, and then we'll go for why you want to go with chemotherapy in this case. That is the question.
High inguinal architectomy is done when there is stage 1 low risk and high risk can do in that case.
No. So you mean to say that if there is a 4 centimeter abdominal para-aortic lymph node, you still want to go ahead with chemotherapy for first?
So metastatic disease, we will give chemotherapy only first, and then we will do a response scan to see, look at the response.
I think any third year can chip in. I think Abhishek. Yeah,
yes, yes, sir.
Do you
yes,
agree
sir.
with
because of raised alpha beta protein, sir, it's a 53,000.
So that is the only region. So I think there is no one answer to the question, but in this case where there is a very huge abdominal mass with a very large testicular lesion, this first thing is if we go for a architectomy for this patient, this will take another 3, 4, 5 days, and if unfortunately there is the disease burden is already very high, so waiting for unfortunately patient develops any infection, all that will delay the curative treatment. So not only the AFP, sometimes even the AFP on the slightly higher side patient is otherwise asymptomatic, we might go ahead with the, but in case where the tumor volume is too high because of this two region, we might go ahead with the chemotherapy. It's not the, suppose if there is a 4 centimeter abdominal lymph node, still you want to go ahead with the chemotherapy with a tumor AFP of say 20,000. So I think for all practical purposes, for exam purposes, and for day-to-day practice, the first treatment for a testicular suspected testicular cancer is the high inguinal arterectomy. This scenario we usually give out of 100 patients, only 5 or 10 patients will go for a upfront chemotherapy. 90% patient will go for the straightforward the high inguinal. I think Dr. Kumar can also comment on this issue. Hello. Vijay, am I audible?
Yes, sir, you are audible. सर का साथ connection नहीं रहेगा सर.
अच्छा, so I think you can comment if Dr. Vanita Nandini is there, they can comment on this, that the need for a upfront chemotherapy versus
I think the need for upfront chemotherapy should, as you correctly pointed out, should be when the risk of doing orchidectomy would be higher than its benefit, which means that the time period for doing orchidectomy, the time for recovery, the time which would delay the chemotherapy would be, in physician's discretion, would be harmful for the patient. The patient may progress, or if there is a large abdominal mass, as in this case, or there are multiple lung metastasis, or there are large supraocular, in that situation, I think it's best that we go ahead initially with chemotherapy and then we subject the patient to orchidectomy. I also wanted to make one more point, Mannavi. This is for all students. Normally, when we talk about semen analysis, we talk only about testicular cancer. Please understand that semen analysis
all patients,
offered in all patients who are post-pubertal and have a expectation to continue the family.
Yeah, it has medical legal implication also. So even in a young metastatic patient, sometimes they want, so you have to discuss not directly but indirectly, just touch that point. And definitely for all curable malignancy like a sarcoma, like a medulloblastoma, you have to ask. There is no escape from that in current scenario. So I think you have you have decided for chemotherapy. So which chemotherapy regime? I think we have only 5 minutes, 10 minutes left. We'll try to wind up. So which chemotherapy you have decided in this case? So we discussed the case in the multidisciplinary team. In view of a very large tumor, decided to go ahead with upfront chemotherapy, and you have done all the relevant investigation, which I told you. The sperm, and ideally the sperm analysis and banking preferably to be done before archidectomy, because theoretically that testis might contain some viable sperm which might lost. So, but in our scenario, practically, usually it is done after the archidectomy. But if someone asks the ideal time for a semen analysis, that is before archidectomy. So you have decided, and the patient is sent to your OPD for chemotherapy. Then how will you start with this case?
I would like to give VIP, sir. VIP is toposide, I is iposfamide, and P is for cisplatin. So with proper pre-medication, capsule.
V for what?
P16, etoposide.
Yes, VP16, that is the name. Why you want to avoid VP in this case? The region? The DLCO. So will this report is sufficient to take a call? The PFT severely restriction and DLCO reduced. Is that is good enough to take a call for bleo, avoiding bleo?
Yes, sir, it is sufficient. If there is restriction in severe restriction, we would usually not give bleomycin. Bleomycin is not given if patients who have any underlying and if there is
DLCO reduced is what we want to see in the report.
Sir, what would I?
DLCO reduced. That sentence is good enough. So I will say that 80% is reduced.
60%.
So I think, so what I meant to say that you should need to see the exact value also na. So the one sentence, I think, Lingraj, what you in a ABVD regime, what cutoff you take for that in your for Hodgkin lymphoma?
Yeah, yes, sir. So, as you rightly said, sir, the cutoff is more important, and when it
Yes.
is mildly reduced, we usually don't omit bleomycin.
Yes.
So anything less than 80 is mild. So if you say
Yes.
less than 60 is something severe. So again,
Yes.
having
So
said that, only that report will not suffice. You should have some cause. So here in this patient, no, the hemoglobin is 7. I would be happy to repeat the BLCO after correction of hemoglobin,
yes.
or maybe, and I may get a different report. So that is my
Yes.
approach.
That what I mean. So that what we do in our practice also. If there is a less than 60% DLCO, we may avoid. But if it is above 60%, there is no as such lung metastasis. We may continue with the end. But the Vijay was asking the question. The region, the PFT might have reduced because of the large abdominal mass. The diaphragm is not moving at all. That may so again I am saying that you should have a what are the as per book, what are the contraindication for bleomycin? That question will be asked. So my request to all this is read in depth for, about the bleomycin toxicity, why there is a increased lung toxicity, why there is a increased skin toxicity, what are the skin toxicities which are manifested by the bleomycin, and what are the absolute contraindication for bleomycin. Mannavi, what are the absolute contraindication for bleomycin?
Total cumulative dose is more than 400 units. If the patient is a previous smoker, and if there is a high exposure to partial pressure of O2, and if there's a previous history of radiation therapy, age is more than 40 years, and there's renal insufficiency.
Yeah, you should tell the most important first, no, Mannavi.
Yes, that I was. Yeah.
And also, if there's a possible
Renal, renal. What you meant by that? So I think what another request from all the students, that if any question is asked, what Lingra saying, start from the most important one and go to the least. Like in a differential diagnosis, we used to tell the first differential diagnosis, but then we go for a rare. If you say the rare one first, everyone like why he is saying that. So start from this in that. So what renal insufficiency?
creatinine deranged.
No, ये तो तुम MBBS का आंसर कर रही हो यार. What is the most common chemotherapy toxic? Nausea, vomiting. So that will, I think you have to read in depth about the chemotherapy drugs and all that, because in this patient the viva will go to the why you want to the because there are good enough data is available which has clearly shown that the avoiding the bleo in a testicular cancer has overall harmful effect on the survival. So until unless, so that is the reason when resident asks the change, I used to tell them to write the region, because after 2 or 3 years we don't remember why we have avoided the bleomycin, and then somebody will look into that and say that isko bleo nahi diya. So if we are avoiding the bleo, that should come clearly into the EMR that these are the regions we have avoided the because we will not remember after 1 year, 2 year why we have not used the bleo in this case. So I think renal insufficiency, the creatine clearance above 60, usually we some say that 50, but the 60 is the above limit where the below which we have to be careful. And age, you said that as the age advances, the reason for avoidance of age is that because as the age advances, the renal function usually deteriorates. So that is the reason the 40 is the cutoff usually they have taken. But in some patients who are otherwise fit, we go up to 45. But beyond 45, I usually avoid giving the bleo because we have given in the past and there was severe toxicity in some patients. So more than 45, no. 40 to 45, some patient with a very good renal function. Otherwise, what you have told about the disseminated pulmonary metastasis, reduced DLCO, chronic smoker, these are the other contraindication. So after VIP, how many cycles will you like to plan in this case?
4 cycles.
Yeah, so you have to tell that in view of a very large volume of disease, I am assuming it to be the high risk. Though the tumor markers are the then you have to commit from the beginning that these are the pre-chemotherapy markers. since the large volume disease, patient is not able to undergo surgery. In view of large volume disease, I am assuming it to be a high risk disease. So I will plan a 4 cycle of the VIP based chemotherapy. So after 4 cycle of VIP chemotherapy, what you will do?
We'll do a response scan, sir.
Before that?
Tumor markers.
Yes. So which is more important in a testicular cancer case with this value? Yes. So again, you have to tell the tumor markers, and so suppose the tumor markers are normalized, then what you will do, and if it is not normalized, then what you will do?
If it is normalized, then we can think of RPLND.
Which investigation you like to go? Which scan? PET scan. Why? Why not PET?
PET scan has no role in NAGCT, sir.
Why? Everyone is doing outside. तो मतलब हर alternate patient में PET होता है. Why it is not? That is the question which I am asking. Why PET is not important in an NSGCT case? So I think these questions definitely will be asked to you in the exam, because whatever the residual disease, irrespective of the metabolic uptake, because the teratoma might not have any uptake, na? So you might get a false negative, which is actually the positive. So whatever the residual lesion, irrespective of the PET positivity or negativity, has to come out. So the PET will not discriminate. So we can't discriminate between the viable disease versus teratoma versus fibrosis by PET. So the CT scan will suffice. And if there is no PET uptake, will you leave the disease? Will you not go for RPLND? No. So that is the reason we don't do. So the answer will be any residual disease which is more than 1 centimeter has to come out in a testicular patient, and the metabolic activity in PET does not have any value in decision making, because the teratoma will not uptake in the PET. Hence, we like to go ahead with the CECT thorax, abdomen, pelvis rather than the PET CT. It has no incremental value in this. So suppose the mass has come down to 2 centimeter, the pararotic mass, and the testicular lesion has come down to 3 centimeter. Then what you will do?
Any residual more than 1 centimeter, we send for RPL and retroperitoneal lymph node dissection.
In this case, you have to tell also that patient will require the orchidectomy. So irrespective of whether there is anything seen or not in the sonography or CT scan, baseline there was a disease in the testis, we like to go ahead with the RPLND along with the orchidectomy. That you have to come. That you have to remove the testis. There is no doubt about that. If the testis is day one involved, whether you see anything in the scan or not, till now we are practicing to go for orchidectomy. Even the USG says that there is no tumor, but you can't be sure. So RPLND with orchidectomy. So if after the RPLND, what are the histopathology and how you will go ahead with that? What you are expecting with that in the histopathological specimen?
So if usually the teratoma component, if it's there, it will not be chemoresponsive. So we can get mixed histologies also, and also we can get.
I think you have to read a little bit about that. So what I meant to ask the question: what is the histopathology seen in the RPLND specimen post chemotherapy? So there are 3 things which we see. One is the complete response, no viable disease. Second is the viable component, that is any other residual. And third is the teratoma. The percentage varies in different series. Some say 40-40-20. So 40 teratoma, 40 fibrosis, and 20 the viable disease. Some say 50-40-10. So grossly it is so you have to say that it may be a mature teratoma, it may be a viable disease, it may be a fibrosis or no viable tumor. So what you will do if there is a teratoma, mature teratoma, and what you will do if there is a viable disease in the RPLND specimen.
Salvage chemotherapy. Next salvage we can do PIP.
will we use the term salvage in this case?
No, sir, not in this case.
Yes. So it will be used, the term will be used as adjuvant. We have removed the so when we will give chemotherapy?
Yes, sir.
When you will give chemotherapy, in which scenario? So the answer is pretty straightforward. When there is a viable disease, we would like to go ahead with 2 more cycles of adjuvant chemotherapy, which may be BEP, which may be TIP, which may be VIP. There is no one consensus for that. Some advocates EP also. We at our center generally wants to avoid the etoposide, so we use either vinblastine ifosfamide or TIP. If there is a mature teratoma, there is no because we have removed the mature teratoma, there is no need of further chemotherapy. If there is a fibrosis or there is no viable disease, no need of. So adjuvant chemotherapy 2 cycle is only indicated if there is a viable germ cell tumor in the post RPLND specimen. So that should be the answer. So I think we are it's already 9:30. I think Manvi, you have to read a little bit about the in depth about the testicular cancer. So next time, I think you can take, when your turn comes, take another testicular cancer and read, and then we can go for a second line discussion also. So I think
I agree with Amit sir. Mannavi, you need to do a lot of reading. Testicular cancer, you won't be spared. In fact, तुम्हारा इसमें discussion सर ने फिर भी standard ले लिया. इसमें तुम्हारा discussion ideally altered regimens पे जाता. HB 7.1 है, albumin 2.9 है, बहुत बड़ा मास है एब्डोमेन में. पहले कौन से छोटे कीमो दोगे, फिर VIP कैसे दोगे, उस सब में.
I think Dr. Kumar also comment on that. I think if yes.
No, I agree. I think this germ cell tumor is the disease that medical oncologists should know in and out. And this was the comment that was made in the current exam as well, that if a resident doesn't know every single thing about germ cell tumor, they deserve to fail. This was the statement made. So
oh my God.
No, seriously, because if you can't manage germ cell tumor, then you are not doing the right thing for your patient. So this Mannavi and all the students, not just Mannavi, just happened that Mannavi presented, but you need to know this in and out. No, there's no excuse for this.
And we have a high volume of testicular cancer at our center. All sorts of complications, whatever written in the book, we see here. So I think you should read a little bit more. I think Dr. Kumar is there, so he can comment also about something regarding this.
नेटवर्क ठीक नहीं लग रहा है. I think
I must not have a connection. We are supposed to do 3 cases. Abhi to 9:30 ke.
No, madam, what we'll do is we'll take Pratik is here. We'll take the investigation report first, and then we'll take the in 10 minutes we'll take the head and neck case. So Nandini, take the investigation wala case first.
Yes. Venkatesh, can you put up the slides of the NGS?
Akhil sir, can you make me host, sir?
If this slide sharing stopped, you can again share without needing to change the. Yeah, you cannot share.
Thank you, sir. Is it visible, sir? Hello?
Yes.
So, good morning. Today, my investigation will be an interpretation of NGS report. So, this is an NGS report which will be reported, and what all things we have to see and what all we have to interpret after seeing an NGS report. So, coming to the first thing, what is the material we have seen? Is it a paraffin block, fixed paraffin block, or it's a liquid biopsy, pleural effusion, or any body fluids? That has to be noted first. And then coming to the age, and also NGS, what we do, this is actually case of primary lung cancer with this metastatic adenocarcinoma. Then coming to the result, So here the results will be given as a tier 1, tier 2, tier 3, tier 4. Tier based stratification will be done as per the guidelines. So what are these tier? So tier 1 is very strong clinical significance which have FDA approved therapy included, which have FDA approved therapies, and their variants of very strong clinical significance. So they are very important to be considered. And there are other 3 more tiers like tier 2, which are variants of potential clinical significance, which are also having some therapeutic and prognostic value. And tier 3 will be variants of unknown clinical significance, and tier 4 will be benign or likely benign variants. So what exactly is tier 1? Tier 1 includes FDA approved therapies in professional guidelines. Standard guideline mentioned FDA approved therapies are useful in those mutations, like standard precision medicine and personalized medicine therapies. And tier 2, FDA approved therapies for different tumors, which are used as an investigational therapies based on the small published case series or case reports. And tier 3 is a variants of unknown clinical significance, which is cancer association with those genes. So they are considered as unknown clinical significance in tier 3. And tier 4 is of benign, no existing or published evidence of cancer association. So in this case, there is a type 1 pathogenic mutation exon 19 of EGFR gene and also exon 20 of EGFR gene. And also there is an amplification of MET gene and EGFR gene. So these are the positive results in this. And what next? Next, the result summary will be given. In this, what they give is mean depth of coverage. Here the value is 960. What exactly is the mean depth of coverage? It is the number of unique reads after doing an NGS, like after defragmentation and doing a sequence study parallel after library preparation and doing a sequence study, we get the reads. So what exactly is the coverage is the DNA sequencing is the number of reads included in a given, that include a given nucleotide, a specific nucleotide, the number of reads which have that specific nucleotide in the reconstructed sequence. So what all we do the sequence reads, the number of reads which have is called the depth of mean depth of coverage, and usually anything more than 500 in our scenario is significant. So here it is 960, it is significant. Then next thing you have to see is the variant frequency in the single nucleotide variants. So variant frequency here is 46 and the other one of 8. So what exactly is variant allele frequency? It is the percentage of sequence reads observed matching a specific DNA variant. So the what percentage of sequence reads which you got, which is matching a specific DNA variant, divided by the overall coverage at that point of locus. So overall, the specific reads which matched what we wanted, divided by overall reads. So that is the variant frequency. Anything less than 5% is not considered valid, and anything more than 50 to 60% we should consider the germline order. So here it is more than 5% and 46% it is considered valid, and so we have considered it as positive. And here we have, if you see, there is tier 4 benign alterations, which I already discussed. Benign alterations, tier 4 no clinical significance, they are just benign. And also genes with no mutations have been seen. Then copy number variations are also detected, which is the MET gene. Copy number is 9.8. Anything more than 6 in our scenario amplification is significant. And also in other reports like microsatellite instability status will be reported, but it is stable in this case. And RNA alteration of fusions, no fusion RNA alterations are detected in our scenario. Total reads are 42,000, which is also significant number. So what are NGS? What are the pathogenic mutations seen? So as we all seen, there is EGFR mutation exon 19 and there is also exon 20. So usually what is the importance? What is the positive result? Importance of interpretation. So EGFR, as you all know, EGFR is most commonly seen around 40 to 50% in non-smokers. So interpretation, mostly it will be in exon 19 and exon 21. Exon 21 L858R. So that based on that, we can use the targeted EGFR drugs like afatinib and all. Afatinib, and so one more important thing is exon 20, which is usually EGFR TK resistant. So based on this report, T790 mutation is present. So it is usually resistant to case. T720M is usually sensitive to osimertinib. And in addition to EGFR, there is MET mutation also positive. So the importance comes with the targeted new drugs like crizotinib, which is approved for MET mutation, or maybe capmatinib, which all can be tried. So based on these positive results, you can interpret accordingly. And what are the pros and cons of NGS? So pros will be the because of the limited tissue found, and individually doing sequence reading PCR is not possible if there is less tissue. So NGS is one which reads multiple genes at the same time. So that is a pro. And cons will be as a few error rates, maybe cost issues and all. So just briefly, the tires, as I already described. The tier 1 is a variance of strong clinical significance with the level A evidence and level B evidence, which are FDA approved drugs in professional guidelines or well-powered studies. And tier 2 are variants of potential clinical significance with FDA approved therapies for different tumors, but with some case reports and case series. And tier 3 of unknown clinical significance, and tier 4 are benign. And one more, the adequacy of cell is important. Usually the cell adequacy in a tissue sample, or if it's more than 40%, it is ideal, but it is the good risk. And anything below less than 10 to 20, not much feasible for the sample adequacy to do the analysis. Thank you. Hello. Hello. Ma'am, am I audible, ma'am?
Yes, yes. Sir, Pratik, Dr. Pratik, Vijay sir, Kumar sir, Amit sir, would you like to ask him?
So I think in this case, what treatment he will plan? So what treatment you will plan for this patient? Patient is affording for anything.
Yes, sir. If patient is affording for anything, we can go for osimertinib itself because it's P790M mutation. And also, if he's affording the MET mutation, we can add a combination drug with either crizotinib or for MET and or capmatinib based on the feasibility and affordability status if he's able.
So you would like to combine osimertinib with with the crizotinib or
osimertinib, yes, sir, with the crizotinib or capmatinib based on the affordability status or MET mutation.
Take my comment.
Yes, Venkatesh, can you go back to the first slide?
Yes, sir.
The next one.
Next one, sir.
Next one, yeah. No, before this one, where there is first page of description. Yes, so here you highlighted that we need to pay attention to paraffin blocks and the tire of variance detected. One more thing you need to pay attention to on this particular page. Can you point that out?
What is the method of sequencing we have done?
Correct. Method of sequencing and panel which is used for the sequencing. This is very important for interpretation because there are several genes included in few panels but not included in other panels. So if you are not having any mutation in your final list of gene, and then if you want to interpret whether it is negative for that mutation, then you need to pay attention to the panel which is being used. If the gene is included in the panel and if it is listed out as a negative, then it is fine to interpret as a negative for the mutation. But if not, then you need to consider any alternative panel. So this is very critical when you have reports coming up from various kind of laboratories, and they all have various kind of gene panels in practice.
Yes.
So that is one thing. Second thing you highlighted was tire of mutations. So apart from tire, there is also level based classification. So can you explain what is the correlation between tire 1, 2, 3, 4 and level ABCD?
So level A, which is usually FDA approved drugs based on the professional guidelines which we have formulated, sir. Level A evidence in tier 1. And level B will be FDA approved drugs, but with a well-powered studies and expert approved consensus. Consensus of expert will be the level B. Both of the level A and level B are in tier 1. But coming to level C in tier 2, which is include level C and D are included in tier 2. So level C is FDA approved therapies for different tumors, but some published studies are with, there are some published studies with proven evidence, and level D is just a preclinical trial or just few case reports which are not approved, but without few consensus, but not approved.
Okay, correct. So basically what you are saying is that tier 1 are the standard line of options and tier 2 are non-standard line of options, but there is enough evidence that they can be still considered when there is no standard option available, while tier 3 and 4 are the ones which we have no information about, so it is difficult to act upon. Is that correct, if we want to summarize in the single line, right?
Yes, sir.
Okay, so now can you go to the next slide, please? Yes, on this one you said there is mean depth of coverage and variant allele frequency. So can we say that this 46% variant allele frequency is out of 960x coverage total?
But not sure, sir.
So why?
I'm not sure, sir.
I'm not able to hear.
I'm not sure of that answer.
Achha. So this mean depth of coverage and the gene location wise coverage are two different things. What I'm trying to ask is that when you look at the variant allele frequency of individual gene, you need to be sure that coverage at that particular location was also sufficient. So here you particularly mentioned that less than 5 variant allele frequency is not considerable, which is true by and large. But if there is sufficiently high coverage at that particular location, then it may be considered as well. So you have to go case by case basis and ask for more details when there is a critical decision to be made. So by and large, 5% or less is a bit less reliable, but not always.
Okay.
Okay, and then you also talked about total RNA filtration reach. So can you explain, there was total number of reads present here, but if in case there is a mutation, then what would be your cutoff to consider fusion detected from RNA sequencing?
Not sure, sir. I don't know, sir. Sorry.
Let me reframe the question. Suppose there was EML for ALK fusion detected here, and the reading says that total 50 reads of fusion out of 42,000 total passing reads. So then, would you consider that as a positive mutation or not?
Not sure. No, not sure, sir.
Okay. So that is also, very critical part that you need to pay attention to when interpreting the mutations out of any NGS report. So RNA fusion detection doesn't have allele frequency just like single nucleotide variants. So there we usually go by the total number of reads. And if the total number of reads are passing the cutoff of 5 fusion supporting reads, then it is acceptable by and large. Okay, so sir, Kumar sir, I think all the questions are covered from my side. Requesting you to please highlight any other point.